Well, welcome everyone. Like she said, my name is Ellie. I am a nurse practitioner based out of Boston, and we're going to be talking about MASLD pharmacotherapy today. So, let's click through here. Good. Okay. If you want to just take a quick second, you can record yourself for attending this meeting. Just take a little QR code. And then, as always, this is another QR code to all of our other amazing programs. There's a lot of information on this website. It's fantastic. So we'll get right into it. So as many of you probably know, there are sort of three pillars to treatments for dysmetabolic management. So really it's controlling obesity and then reducing CVD risk as well as targeting that NASH, which we're really going to be focusing on today. So of course, you guys know obesity, lifestyle, diet, activity, that's never going to go away. But we have this huge not new, but newly talked about, class of weight loss medications, which we'll dip into just a little bit. And then moving over to reducing that CVD risk, we're really talking about treating type 2 diabetes, reducing hypertension and dyslipidemia. And then lastly, we're going to talk about liver-directed treatment, so vitamin E, Pio, and Resmetirom. All right, so getting into a little bit more of the GLPs, I feel like it's a big hot topic still over the last couple of years. So as many of you know, what it really does is it stimulates glucose-dependent insulin secretion, suppresses that glucagon, and then delaying that gastric emptying. So really those GLP-1 RAs are analogs of the gut-derived incretin hormone, and they lower blood glucose and cause that weight loss. So in our hepatology practices, whether you are in a hepatology specific practice or a general GI provider, some people are comfortable prescribing these medications. Specifically, semaglutide 2.4 milligrams once per week has been successful in showing significant reduction in mass without worsening the fibrosis and overall improvement in liver fibrosis. So something to really think about potentially in those patients that are overweight and overweight with the MASLD. They can be really helpful. The other consideration you definitely want to take into account is, I'm a general GI provider, so I always have to ask, before I send these patients for endoscopies or colonoscopies, are you on these? Because as we know, it delays that gastric emptying, which totally increases the risk of aspiration if you're putting them under. And then lastly, just thinking about timing of that last dose. So you really don't want it to be any more than 7 days before the procedure, because again, risk with anesthesia. Okay, so getting into a little bit more liver specific, there's evidence about vitamin E at a dosage of 800 units twice a day. It's really indicated in patients that do not have diabetes with MASH, without cirrhosis. So not really helpful with patients with diabetes. There was a trial, Pivens trial. It's really the landmark study that showed vitamin E does improve liver histology in about 43% of patients, which is really great if you think about it. I think the limitations are obvious. We're not using it in hypertensive or diabetic patients, so that really sort of limits the pool that has access to this. In the 2023 guidelines suggest that vitamin E may improve NASH, but there is some contraindication, or excuse me, conflicting data. The other guidelines suggest that they don't recommend it, which is interesting. So potential risk, you always want to think about bleeding, prostate cancer. It's a really discussion with the patient that's sitting in front of you. And then Pio. So Pio dosed at 30 to 40 milligrams per day. This is indicated for patients with MASH with or without diabetes, so can be helpful in that sense. Similarly, Pivens trial showed that there's no benefit over placebo However, significant benefits of Pio were observed for some of the secondary outcomes with improvement of cardiovascular risk. So very helpful with those patients with diabetes, hypertension, hyperlipidemia, that kind of thing. You always have to consider the safety, risk of weight gain, edema, bone, potentially in women, and some associated risk of bladder cancer, which is interesting. And then finally, the gold star, resmetirom, it's all the rage. So March of 2024, it received its first FDA approval in conjunction with diet and exercise for treatment of adults with non-cirrhotic NASH and with moderate to advanced liver fibrosis. So really those patients that are getting an F2 or F3 fibrosis stage. It's a thyroid hormone replacement beta B or beta agonist. So it selectively binds to and activates that receptor in the liver. I won't bore you too much with the mechanism of action, but just briefly, resmetirom, again, is that selective thyroid hormone beta agonist, and it targets mostly the receptors in the liver. And it's sort of mimicking thyroid hormone T3, but it acts selectively in the liver. So it's avoiding those unwanted effects on the heart and other tissues. So when you activate the beta receptor, resmetirom increases fat burning, which is lipid oxidation, decreases fat production or lipogenesis, and then it lowers liver fat and blood lipids. So both the cholesterol and triglycerides come down as an effect. So in NASH, this leads to really reduced liver fat and inflammation, slower progression or reversal of fibrosis, and overall liver function improves. All right, so this is the trial. So it's an ongoing phase 3 randomized controlled trial with resmetirom in NASH with liver fibrosis. So about 100 people were randomly assigned to sort of 3 different prongs, 80 milligrams, 100 milligrams, or placebo. And the 2 big endpoints they were looking at was NASH resolution and about how much improvement. So really an improvement or reduction in fibrosis by at least 1 stage with no worsening of the NASH was found, which is huge. So, you think about those patients, specifically those young patients that are maybe F2, and if we can reduce them to F1, that's a huge thing. Sort of looking at side effects, really, diarrhea, nausea, the most frequent, and there wasn't really a change in serious adverse effects across all of those groups. And again, resmetirom 80 milligrams, 100 milligrams were superior to placebo, with respect to the NASH resolution and improvement in liver fibrosis by at least that 1 stage. All right, so getting into sort of the practical considerations for management. You got a patient sitting in front of you. Do we start them on it? Do we not? That's the age-old question for APPs. Really the ideal patient for treatment is, of course, the adult with non-cirrhotic MASH, F2, F3, and you have to give education about diet and exercise. Do not overstate that. It's really important that they're on board. There's a plan in place on what they're going to do, specific changes, and I always recommend measurable. Right? We talk about those SMART goals, measurable changes, right? So that they can really stick to it. You always want to look at drug-to-drug interactions. On the left-hand side, you have some antivirals, just kind of looking through that. And then over on the right, people get, funky they get worried about, statins and increasing liver enzymes. But, we can really see a benefit with statins, particularly at those lower doses. So going forward, there definitely is some room for additional discussion. So of course, this ongoing evaluation continues during that the trial. Um, we'll probably need to restage fibrosis with those non-invasive testing, such as the FibroScans, getting CAP scores, ELF scores, that all good things. And then currently expert panels are working on cut points and periodicity for testing, so that's a little bit more standardized across the board. And then we still have some questions, of course. Insurance, age-old question for us as APPs. We're always asking about insurance coverages. Um, Again, how often do we repeat staging? How often do we get lab testing? Like there's all data that should be coming down the pipeline for that. When will we need duration of treatment recommendations? When to stop treatment? I know my patients always ask me, how long am I going to be on this? And am I on this for the rest of my life? You can tell them we're not sure yet, but we'll know shortly. Awesome. And thank you for your time.
Thank you, Ellie. That was wonderful.